In part 2 of this lecture on periapical pathology, we're going to have a look at a number of other reactive and neoplastic conditions which may affect the periapical tissues. We've had a look at the periodontal ligament space itself, but of course the periodontal ligament is surrounded by bone, and in relation to infection and inflammation, the bone immediately surrounding the apex of teeth can also respond. Now these terms that are used, which maybe not used very often, but you'll find them there in the books, are rarefying osteitis, which really means that there is a little bit of radiolucency associated with it. We've talked a little bit about that in terms of the increase in the periodontal ligament space as you get periapical periodontitis. But really what I wanted to show this picture for was for the other condition, which is called focal sclerosing osteitis. And you can see it in the radiograph here. And if you have a look at some of these teeth, which are obviously very heavily restored, the periodontal ligament space is widened, but there is a radiopacity just extending from that, which is evident on the lower first molar here, but also quite markedly in relation to this lower molar here. And this is an attempt, I guess, for the bone becomes a bit sclerotic. So it's going to be more radiodense, and it's attempting to wall off the inflammatory process which is there. And you'll find that, in fact, that in some cases, even after you remove the tooth, that doesn't necessarily completely disappear, and you might find these little patches of radiopacity in the jaws for a while after teeth have been extracted. Some people refer to them as bone scars, but they're just little areas of focal sclerosing osteitis. The other tissue, which we've not really spent very much time talking about in the periapical space, is cementum. And cementum, as you are aware, is laid down in two forms, acellular and cellular cementum, as the tooth develops, and cementum is gradually laid down over life. But that can be excessive, and the term that we use for that is hypercementosis. And so it's pretty common, and generally speaking, it's just an age-related phenomenon. But you can get really excessive cementum because of a number of different clinical circumstances. So you can get hypercementosis in the circumstance where a tooth does not have an opposing tooth. So you can get that circumstance, for example, by if you have a tooth which has had its opposing tooth extracted, and you might get hypercementosis as the tooth is essentially trying to recreate some form of occlusal contact. But you also see that in unerupted teeth. And so, for example, unerupted lower eights, impacted eights, quite often have a lot of cementum on them because they've never really come into function. Inflammation. We'll quite often see hypercementosis associated with a periapical granuloma, or perhaps more understandably, in teeth that are mobile, and that's presumably part of the whole process of trying to stabilize the tooth in a patient who's got chronic periodontitis. An interesting condition, which is actually now very rare, it's a bony condition, is Paget's disease. It tends to be a condition of older patients, particularly men. And what happens in Paget's disease is that the control of the turnover of bone is disrupted and the bones get very sclerotic and you get hypercementosis. And then there are some circumstances that we don't really know the cause and we call them idiopathic changes. But this is an example of hypercementosis in a patient with Paget's disease. The bone of the jaw here has become very patchily radiopaque. You can look at the outline of the cementum on these tooth roots. You certainly would not be wanting to try and to be extracting a tooth like that. And this is really quite gross in terms of the amount of cementum that's here. We don't very often see them to that extent, but hypercementosis is a prominent part of Paget's disease. Histologically, you might see something like this, and again, not necessarily in Paget's disease, just some occasionally we see very marked hypercementosis on teeth. You can, on this tooth outline, you can see where the outline of the dentine should be, and there's a very thick layer of cellular cementum. And when you have a look at it at higher power, here's our root here, dentine, the normal cementum, and then this cementum, which actually looks very like bone. And in fact, cementum is biochemically identical to bone. And so this does look very much more like bone in its structure. So therefore, it wouldn't be surprising that on occasions the periodontal ligament space can be obliterated, and you get fusion of this hypercementosis with the bone of the alveolus. And this is termed ankylosis. And so there is no periodontal ligament space. There is no way in which you can get movement on this tooth to get it extracted. And you can see what has happened in this case, that in fact a large piece of the alveolar bone has come out with two teeth attached to it. And this is a problem on the lone standing upper molar in an older patient. At times you put the forceps on the tooth, and when you start to move the tooth, you see the whole of the tuberosity moving. And it may be that there has been a certain amount of ankylosis or fusion of the tooth to the bone, and then what is required is a very complex surgical extraction. There are some other reactive processes which go on at the root tips, and this is a rather unusual one which we term Cemento-osseous dysplasia. There are various forms of it, but I'm going to particularly talk about the periapical form. And these again are reactive lesions which occur in younger to early middle age, most often in females, very often actually in black females. And what you get associated with the apex of the tooth is multiple radiopacities. Very often they're situated in an area of radiolucency, so there's a loss of bone, and then there's these radiopaque masses within that. And you can get it around tooth roots in a patient who's dentate, or even at times in edentulous areas. And histologically, they look like fibrous connective tissue, not really very inflamed, but with lots of trabeculae of woven bone within it. And so the overall pattern of the histology we call fibro-osseous. Now this is something that we'll come back to in a lot more detail in the oral diseases part of the course. But just to introduce as an idea, here's some lower central incisors. And you can see these radiolucencies, and within that there's little radiopaque masses beginning to appear. And it tends to classically occur on lower incisors. And unfortunately, quite often you may get a patient who's had a history of this, and they've had all of these teeth root treated. The lesions have not improved. The teeth actually were vital. And it can be quite tragic, and patients can lose these teeth for reasons that in fact they didn't actually need that operative treatment in the first place. Cemento-osseous dysplasia can be spectacular though, and this is a florid form which is affecting quite a large part of the mandible here and has resulted in a pathological fracture. And you get these irregular radiopacities, big masses of rather fused, very poorly formed bone and cementum-like tissue, which can cause particular problems. And so the histology varies from very radiopaque material and the radiograph, which would look histologically like this, with lots of poorly formed bone, to the more radiolucent areas, which have got lots of fibrous tissue with little pieces of bone forming within that. So we'll go back through cemento-osseous dysplasia. That will be come back to again later on in the course. Now that's the reactive lesions. As I said, there's one neoplastic lesion, and this is cementoblastoma. This again tends to occur in relatively younger patients, and it is a radiopaque lesion which is attached to a tooth root, most often the mandibular first molar tooth. And histologically, it is large sheets of cementum. It fuses with the tooth root, and it looks like an osteoblast or cementoblast, whatever you call them, lots of very active cells within that tumour. And in fact, histologically, it's very much analogous to a similar tumour that we see in bone, which we call osteoblastoma. And the thing that distinguishes a cementoblastoma and allows you to make the diagnosis is that it is attached to the tooth root. So here's our radiology, lower first molar, fusion of this radiopaque mass to the roots. It's got a radiolucent outline to it, so it's separate from the surrounding bone. You can imagine a bit of a nightmare for an extraction, but here is tooth which has been removed. Again, you can see very clearly that this mass is fused to the roots of the tooth, and histologically as well, it fuses. In the histology at higher power, it's really pretty crazy looking. Very poorly formed bone or cementum-like material with lots of very active cells. To the unwary pathologist, sometimes these are unfortunately called malignancies and cause a lot of scare for a patient until we get the proper diagnosis. But they are benign neoplasms. Once they're excised, they don't recur. And although they can be a diagnostic challenge to the unwary pathologist, if you see something like this which is attached to the root of the tooth, it's pretty much going to be a cementoblastoma. So a little further reading, if you wish, in relation to the inflammatory components of it. Have a read further through the dental caries book, but also in terms of the pathology, you see chapter 5 in the New Soames and Southam. That will give you a bit more detail on all that we've covered in these two videos. And so that's us for periapical tissues, and we'll pick up some of the important features in this when we do the virtual microscopy class in a little while.